Ladies and gentlemen, and I want to welcome you all to Health Committee, and I want to especially welcome our guest today. We are studying the government's role in addressing prescription drug abuse, and we have before us 4 witnesses from the Department of Health. Is there a doctor here? We have Robert Ianero. Did I pronounce that right? The Director General of Controlled Substances and Tobacco Directorate, Healthy Environments and Consumer Safety Branch. My goodness, that's a long title and a lot of responsibility. And we have Sandra Bruce, Director General of the Non-Insured Health Benefits Directorate, First Nations and Inuit Health Branch. Welcome. And we have Deborah Gillis, Acting Director General of Interprofessional Advisory and Program Support, First Nations and Inuit Health Branch, Health Canada. Welcome. And we have Dr. John Patrick Stewart, Senior Executive Director of Therapeutic Products Directorate. Now, it's my understanding that we have 1 presenter today, and usually what we do is we allot 5 to 7 minutes per person. So what I'm going to do today is give you 20 to 25 minutes, Mr. Yano, just so we can get all our, I know the committee is very anxious to hear what you have to say. So let's begin.
Merci, Madame la Présidente.
Thank you, Madam Chair.
for the opportunity to appear before the Standing Committee on Health to speak to this important issue. My name is Robert Ianniro, and I am the Director General of the Controlled Substances and Tobacco Directorate in the Healthy Environments and Consumer Safety branch of Health Canada.
All of whom are responsible for programs that collectively support the government's ongoing efforts to protect Canadians against the risks associated with prescription drugs. Dr. John Patrick Stewart is the Senior Medical Director in the Health Products and Food branch and is here and able to speak to Health Canada's role in establishing and maintaining prescription drug accessibility while decreasing the risk of abuse associated with certain drugs. I am also joined by Ms. Deborah Gillis and Ms. Sandra Bruce, both Directors General from the First Nations Inuit Health Branch, who are able to speak to the range of activities underway to protect and promote the health of First Nations and Inuit. Les membres du comité savent.
As committee members will be aware from various media reports and other sources, prescription drug abuse is a public health and safety issue in many areas across the country. It has been marked by increases in rates of consumption and, in many cases, addiction and death due to overdose. While there is little national-level data on prescription drug abuse presently available in Canada, there is growing evidence of the nature and scope of the problem.
About OxyContin and fentanyl. These drugs are potent opioids used frequently for the relief of moderate to severe pain. According to the International Narcotics Control Board, Canada is currently the world's second largest consumer of opioids per capita, second only to the United States. Opioid pain relievers have been used for the treatment of cancer pain and in palliative care settings for many years. However, in the 1990s, these drugs started to be marketed for treatment of chronic, non-cancer pain like back pain and arthritis. OxyContin quickly emerged as one of the top prescribed opioids for pain management. Unfortunately, OxyContin became very popular for non-medical use due to the euphoric high that users obtained by crushing and injecting this drug. Shortly thereafter, communities began reporting public health concerns related to the abuse of OxyContin, as well as public safety concerns related to diversion from legal sources to the illicit market. There is growing evidence that prescription drugs have become popular among youth, and they increasingly represent a path to addiction for both youth and adults. Il existe de plus en plus d'épreuves.
According to the most recent youth smoking survey, prescription drugs are now the third most commonly used group of substances among Canadian youth after alcohol and marijuana. There are several overarching factors contributing to the growth of this problem. These increasingly represent a path to addiction for both youth and adults.
Contributing to the growth of this problem. While Canadians understand the dangers involved with illicit drug use, there is not the same understanding of the harms related to prescription drugs. Prescription drugs are commonly perceived as safe. This misconception directly affects consumer practices on use, storage, and disposal of prescription medications. The second factor relates to inappropriate prescribing practices. Prescribers, including those from the College of Physicians and Surgeons of Ontario, have acknowledged that their lack of knowledge and training for pain management has contributed to the growth of the problem. According to a Canadian study conducted in 2009 on curricula in health professional education, veterinary students receive 5 times the training on this subject than medical students. Par conséquent,
As a result, some Canadians leave their physicians' offices with prescriptions for inappropriate or excessive quantities of powerful medications without proper information about these drugs and without the appropriate follow-up from their healthcare team.
Demand for treatment for opioid dependence has increased in many jurisdictions. In Ontario, admissions to publicly funded substance abuse centres rose by 129% between 2004 and 2011. Finally, lack of awareness of safe storage and disposal practices is an important driver. There is evidence that the home represents a common point of access to medications for abuse for many Canadians. Many unused and expired medications remain in unlocked medicine cabinets, making them vulnerable to diversion and abuse. For example, the results from the 2011 Ontario Student Drug Use and Health Survey indicated that 67% of youth in Ontario who reported misusing prescription drugs obtained them from within the home as a result of a prescription from a family member. Effectively combating prescription drug abuse requires a coordinated and comprehensive response across a broad range of sectors. FPT governments share responsibility for addressing prescription drug abuse. The provinces and the territories are responsible for the delivery of healthcare services, which includes providing treatment services and, through regulatory colleges and licensing bodies, for establishing training requirements and practice standards for health professionals. This point is reinforced in the recent National Prescription Drug Abuse Strategy developed by the Canadian Centre on Substance Abuse, called First Do No Harm. Les provinces et les territoires ont
Provinces and territories have expressed willingness to collaborate with Health Canada to address the issue. Early opportunities for collaboration to support better collection and sharing of information and improve prescribing practices were recently endorsed by FPT Ministers of Health this past October.
Prescription drug abuse supports that of the provinces and the territories. This is realized through our role as a regulator under the Food and Drugs Act and the Controlled Drugs and Substances Act, and as a service provider for First Nations and Inuit. I will take a few moments now to speak about Health Canada's role in ensuring the overall safety of drugs on the market, including safeguards that are in place to promote proper use. Under the Food and Drugs Act and its regulations, a new drug will be issued market authorization if, after a risk-based decision-making process, Health Canada determines that the drug demonstrates an acceptable level of safety, substantial efficacy, and high quality. The regulations require that a manufacturer file a new drug submission with substantial data to support the safety, efficacy, and quality of the drug for its intended use. Sur la base de l'information présentée,
Based on the information submitted, Health Canada's scientists determine whether the data meet the current standards to support approval and whether a drug should only be available through a doctor's prescription.
taken into consideration during the review process. If a drug has a significant risk of addiction and/or abuse, substantial data supporting the efficacy of the drug must be shown in a serious condition, such as severe pain, to justify these risks. Additionally, through the approval of the final product monograph, information on the potential for addiction and abuse is communicated to healthcare providers and consumers. Physicians are advised to prescribe and handle such drugs with caution, assess patients for their clinical risks for abuse or addiction prior to prescribing the drug, and routinely monitor patients for signs of addiction and abuse. The product monograph further contains information for the consumer about the dangers of a drug with addiction and abuse potential. Patients are advised to take the medication only as indicated by the treating physician, to tell their doctor if they have questions or concerns about the addiction or abuse, and to keep the medication safe, never giving it to anyone else as it may be abused and cause serious harm, including death. Manufacturers may also be required to implement a specific risk management plan as a condition for approval. Such plans may include monitoring of events related to abuse and addiction once the drug is on the market, as well as education materials for healthcare professionals and patients. Once a drug is on the market, Health Canada monitors its safety through surveillance of serious side effects reported within and outside of Canada. As new information becomes available about side effects, the product monograph is updated to inform physicians and patients about the new safety information. The risk management plan can also be altered to address changes in risk, or a drug can be removed from the market if experience with the drug shows that its benefits no longer outweigh its risks. Several drug classes such as opioids, central nervous system stimulants and depressants, cannabinoids, and nicotine-like compounds are already well known to be potentially addicting and have abuse liability. To this end, Health Canada put in place a guideline to assist manufacturers in conducting studies, assessing whether a new drug produces acute effects such as euphoria or drug-liking effects that could lead to addiction or abuse. Results of such studies are required to be included in drug submissions and help guide benefit-risk assessments and decisions relating to drug approval, scheduling under the Controlled Drugs and Substances Act, prescribing information within the product monographs, information for the consumer, and risk management plans. Through this work, Health Canada works to establish and maintain prescription drug accessibility while decreasing the risk of abuse associated with certain drugs. Protecting the health of Canadians remains the primary concern. Public awareness among prescribers, dispensers, and patients about the problems with drugs that are addictive or that could be abused promotes good medical practices, fosters dialogue, more importantly, helps ensure patient access to effective medications while protecting them and others from potential harms of these types of drugs. Je parlerai maintenant brièvement.
I will now speak briefly to some of Health Canada's work to ensure that First Nations and Inuit have access to health services, including mental health and addictions programs, and to prevent prescription drug abuse in First Nation communities.
First Nations have reported significant challenges with the abuse of prescription drugs. To respond to this serious problem of substance abuse, Health Canada invests approximately $92 million annually in addictions prevention and treatment programming. This investment includes funding to support a network of 55 treatment centers as well as drug and alcohol prevention services in over 550 community-based prevention programs. Of note, in 2013-14, Health Canada worked in close partnership with the Ministry of Health in Ontario, as well as the Chiefs of Ontario, and invested $2 million to support First Nation communities in Ontario where the problem of prescription drug abuse is most acute. Health Canada's investments in addictions and treatment programs are part of a larger effort to provide First Nations and Inuit with a comprehensive system of mental wellness services. Health Canada also administers the Non-Insured Health Benefits Program, or NIHB. It provides coverage for a limited range of medically necessary goods and services, including prescription drugs, to eligible First Nations and Inuit. Au cours de la dernière décennie,
over the last decade, the Non-Insured Health Benefits Program has introduced a wide range of client safety measures to prevent and respond to potential misuses of prescription drugs, to help ensure that First Nations and Inuit clients can get the medications they need without being put at risk.
Sending automated real-time warning and rejection messages to pharmacies to alert them to situations of potential misuse when a client attempts to fill a prescription that requires a pharmacist's intervention before the claim can be processed. Placing restrictions on the coverage of drugs of potential abuse, including those that present health risks or risk of diversion. Introducing dose limits that limit the amount of a particular drug that a client can receive per day. To detect patterns of potential inappropriate prescribing and dispensing and other safety concerns, the NIHB program has a formal surveillance program called a Prescription Monitoring Program, or a PMP. Though the PMP was originally introduced in 2007 to focus on clients who have been double doctoring, it has since been expanded to address clients who are on high doses of one or more drugs of concern. Clients whose drug utilization profiles indicate that they are at high risk of misusing certain drugs, opioids, stimulants, or benzodiazepines, are placed in the PMP. Clients listed in the PMP face restrictions in terms of the approval process for these drugs. Since November 2012, NIHB have been using the findings of the surveillance work to engage prescribers to gain insight into the reasons behind high doses of opioids and benzodiazepines, and work with them to impose restrictions, taper doses, and encourage the use of alternative non-opioid medications as appropriate. Preliminary results of these initiatives indicate that the impact is positive. In the last 12 months, the number of high-dose benzodiazepine clients has decreased by 36%, and the number of high-dose opioid clients has decreased by 7.5%. À l'avenir, le programme des services de santé.
Going forward, the Non-Insured Health Benefits Program will continue to monitor the use of opioids and other drugs of concerns. It will continue to adjust existing limits and introduce new restrictions and measures as appropriate.
Physicians, other prescribers, pharmacists, and other public drug plans in our efforts to ensure the safe use of prescription drugs among First Nations and Inuit clients. Madam Chair, I would like to close my remarks today by spending a few moments talking about the Controlled Drugs and Substances Act and Health Canada's role in the National Anti-Drug Strategy. La loi réglementant certaines drogues.
The Controlled Drugs and Substances Act, or the CDSA, provides a legislative framework for the control of substances that can alter mental processes and that may cause harm to the health of an individual or to society when diverted to an illicit market or used illicitly. The CDSA has a dual purpose: to protect public health and maintain public safety. It prohibits activities such as the production, sale, and possession of substances such as opioids, unless authorized for legitimate medical, scientific, or industrial purposes through regulations or exemptions. It includes offenses and penalties that range from a fine to life imprisonment.
Regulations that are relevant to the discussion of prescription drug abuse. The regulations provide a framework to facilitate the use of prescription drugs for medical treatment. Compliance and enforcement also forms an important part of the drug control objectives of the CDSA. Health Canada is active across the regulated supply chain to verify compliance with the CDSA and its regulations. For example, licensed dealers comply with regulations, setting out reporting and record-keeping requirements, as well as security measures aimed at minimizing diversion. Pharmacists are required to maintain records of controlled substances purchased and are accountable for prescriptions dispensed. En terminant, j'aimerais souligner
As a final comment, I would like to highlight some of the lessons learned under the National Anti-Drug Strategy, a strategy based on 3 key areas of action: prevention, treatment, and enforcement, which I believe are informative in identifying actions to address prescription drug abuse.
we have seen marked progress in discouraging youth from using illicit drugs and supporting innovative treatment services for individuals addicted to illicit drugs. For example, the government led a successful mass media campaign entitled Drugs Not For Me to raise awareness among youth and parents about the dangers of illicit drugs. This campaign saw impressive results. Youth are now more likely to say that they would refuse to take illegal drugs, and more parents engage their teens in discussions about the risks of taking drugs. The government has also made significant progress working in partnership with law enforcement to prevent the production and diversion of illicit drugs. The National Anti-Drug Strategy and its successes provide a strong foundation upon which to support action to prevent prescription drug abuse. In light of the recent Speech from the Throne commitment to expand its scope, work is underway to assess how the prevention, treatment, and enforcement successes of the National Anti-Drug Strategy can be applied to addressing this issue. Merci, Madame la Présidente.
So very much. And now we're going to go quickly into our Q's and A's, 7-minute rounds, and we'll begin with Ms. Davis.
Thank you very much, Madam Chairperson. And I'd like to begin by moving to give notice for the following motion, that the committee may meet in camera only for the purpose of discussing A, wages, salaries, and other employee benefits, B, contracts and contract negotiations, C, labour relations and personnel matters, D, a draft report, E, briefings concerning national security, and that all votes taken in camera be recorded in the minutes of proceedings, including how each member voted when recorded votes are requested. Thank you. Madam Chair, I'd now like to address my remarks to the witnesses and ask a couple questions. First of all, thank you to all the officials for being here today, and to Mr. Ianero, thank you for your remarks. I wanted to begin by picking up what you say in your presentation. You said at the beginning that there's little national level data on prescription drug abuse presently available in Canada, and that there's growing evidence of the nature and scope of the problem. And I just wonder if you're aware of the Special Parliamentary Committee on the Non-Medical Use of Drugs that issued its report in 2002, because in that report there were a number of recommendations, because it did deal with prescription and illicit drugs, that really pertain to this issue. And so I want to find out what has been done with those recommendations and whether you're even aware of them. It was an all-party committee. These recommendations were unanimously adopted. So, for example, recommendation number 26 said that the committee recommends that a renewed Canada drug strategy include in its priorities the development of a strategy specifically relating specifically to the misuse of over-the-counter and prescription drugs in Canada. Recommendation 27 recommended that the Government of Canada assist and encourage the province and territories in the development and maintenance of comparable real-time databases so as to track better the prescribing and dispensing of commonly misused prescription drugs. And then there was another recommendation, I'm just pulling out a few, that said that consideration should be given to include questions on licit and illicit substances in every cycle of the Canadian Community Health Survey every 2 years. Now, so these are not new issues. These were identified more than a decade ago. I realize that the current government wasn't the government then, because this is 2002, but nevertheless, it seems to me that it's a place to begin, and it's a place to have some accountability as to whether or not the good work of a committee of that day has ever really been followed through, because it's a bit surprising to hear you say today that it was only in October now that the provinces and territories are sort of saying, well, they're willing to work on this issue. I mean, this is more than a decade old. So what has been done in that time period, if, you know, specifically on those specific recommendations that I just referenced?
Go ahead.
I can begin, and I guess to start, I would say that yes, we are aware of the report that the member has referenced. I would say generally that the same challenges and recommendations that were made at that time continue to be the case today. When the National Anti-Drug Strategy was introduced in 2007, so this replacing the Canada's drug strategy, it was refocused, given reports from law enforcement that indicated at that time that there were significant issues with illegal production of synthetic drugs like ecstasy, and even some concerns around marijuana grow operations. And there was also concerns at that time that youth and vulnerable populations were seen to be at risk from illicit drug use. And the government then focused its activities and investments on dealing with this critical public health and safety challenge. As I've indicated, and as the member has indicated, the government has announced in the speech from the throne that it is committed to expanding the National Anti-Drug Strategy to address the growing problem of prescription drug abuse. So a clear commitment has been made to address the issue. I think we'll be able to leverage the experience and the knowledge and the best practices from the National Anti-Drug Strategy in our efforts. And
could I just be clear, though, because what I remember in 2007 is that what the government, the Conservative government, did was they dropped harm reduction, a very important pillar of the 4 pillars. So they did that. That's on the record. But there was nothing done on these recommendations. There was no. Was the drug strategy amended to include the need for a real-time database, or for including this information in the Health Canada survey, or making this a priority? Like, I don't see that. So there is a sort of a lack of accountability here. So even this present government didn't even address this beginning in 2007, other than dropping harm reduction, which has had a lot of serious consequences in Canada.
So I do think that progress has been made, in particular in the areas of First Nations and Inuit, and I think my colleague Ms. Bruce can probably speak to some of the advancements made in that area. With respect to the surveys, questions relating to prescription drug abuse have been included in surveys. It's part of how we're continuing to, I guess, monitor and figure out the specifics of the problem. There are still significant data gaps from a pan-Canadian perspective. Many of the recommendations that were made at that time, like I said, continue to exist today.
More time? Okay. What is the status now of OxyContin? My memory is that it's now basically it's being delisted, at least from the federal list. Am I correct?
So on OxyContin, maybe I can just ask that my colleague, Dr. Stewart, speak a little bit to.
Time is up, so perhaps if someone else wants to pick that up, that would be great. We'll now go to Ms. Adams.
Thanks very much. I think the challenge that we have, if an individual comes forward to you and offers you an illicit drug, heroin or some such, it's pretty clear to everyone around the table that that's an obvious hazard. And the challenge we face with prescription drugs is that it comes in a medicine bottle. And so somehow when an opioid or a stimulant or a depressant is handed to you and it's in a medicine bottle, I think the concern is that children especially just aren't quite aware of how large that threat is. Could you tell me a little bit about some of the metrics that are being used to monitor how large this problem is, how aware parents are of this problem, and the sources of that data?
Mr. Iannero?
Go ahead, sir. You have something to add?
Oh, Dr. Stewart, go ahead.
So I can speak from the licensing perspective around labeling. And certainly when a drug comes in for approval and it's clear that it has addictive or abuse potential, we spend a fair bit of time looking at the labeling and ensure that the labeling, when the product is authorized in the market, is clear to both the prescribers, the pharmacists, and in the Part 3 of the product monograph for consumers or patients, that the risks of abuse and the potential outcomes of that are clear, so that if they're looking for information around the product, it's there in the product monogram. We also make recommendations around how it should be stored, how it should be disposed of, that sort of information that allows consumers, if they look for it, to be aware of the dangers of leaving the product around for others to use that don't understand those risks, and for the actual user to not inadvertently use it inappropriately and run into issues associated with that.
And if I just may add, Madam Chair, I can provide some specific data on surveys that have been conducted. So there are a few, and I'll try to work through them quickly. One is the Canadian Alcohol and Drug Use Monitoring Survey, what we refer to as CADMS. So this is a general population survey of alcohol and illicit drug use among Canadians 15 years and older. And according to the results in 2012, there was an estimate that 410,000 Canadians reported abusing a psychoactive pharmaceutical, including opioids, stimulants, tranquilizers, and sedatives. So that was one of the, I think, to carry on to one of the previous members' questions, we have incorporated questions in our national surveys to determine the extent of the issue with prescription drug abuse. The other, an additional one is Youth Smoking Survey. It's a school-based survey of Canadian youth in grades 6 to 12, and it captures information related to tobacco, alcohol, as well as drug use. And that survey includes just under 51,000 students that represent approximately 3 million youth. And according to those results, in 2010-11, 5% of students reported using psychoactive pharmaceuticals to get high. There also was the Ontario Student Drug Use Health Survey, population survey of Ontario students in grades 7 through 12, and in 2011, the survey captured over 9,000 students, and according to that survey, 14% of Ontario youth reported using an opioid pain reliever non-medically at least once in the past year. So the results of these surveys indicate that prescription drugs are the third most commonly used substance in the general population, and again, as I mentioned in my opening remarks, amongst youth are only behind alcohol and marijuana. And there's similar statistics that have come out of some studies as well for youth in the United States.
This is obviously an issue that will require the collaboration of the provinces and territories. Can you tell me what work is underway to ensure that the provinces and territories are involved?
Absolutely. There's no doubt, as I mentioned, it's a shared responsibility, and I think that some work is already underway. In fact, at the recent health ministers meeting, the FPT Ministers of Health actually endorsed a proposal which provides early opportunities for collaboration in some of the areas of concern that need work. Better collection and sharing of information is one area, and improving prescribing practices across jurisdictions is another. So I think there is already a clear momentum upon which to build. And I think there's a commitment from the federal level as well as our PT colleagues to start tackling this problem that I think all appreciate exists and is one that we need to turn our attention to.
I was also going to add that more of an operational level, we're now, when we approve a new opioid, when it reaches the NOC stage, when it gets a notice of compliance, we're making sure that we're sending out information to a number of affected parties, provincial level, bodies, as well as pharmacists, physician associations, so that they're aware that a new opioid or a new change in indication has hit the landscape of opioid medication, so that they can reflect on that and better prepare how they might strategize at a provincial level to ensure that this product doesn't as well end up being abused, or they can risk manage how this might roll out and be used with the various hospital levels and patient groups.
One of the surveys that you had mentioned was Ontario-based. Is there currently a forum to exchange information with the provinces when it comes to data on prescription drug abuse?
I would say that generally that's one of the challenges is actually having first of all, even having the data available is a challenge, and then of course finding a way of sharing it. And one of the challenges that exists with prescription drug abuse information is that it's not collected in every jurisdiction. In the jurisdictions that it is collected, it's not always collected in the same manner. And this is one of the key areas of focus, the information gaps and the sharing of that information, collecting that information in a way that is uniform and consistent and could therefore be used to compare and to come up with interventions is one of the challenges. And I think that's something that we would look at working into the introduction of prescription drug abuse activities under the National Anti-Drug Strategy.
And then even international comparators. Which countries are leading the way in actually aggregating data on this subject matter?
I would say that the U.S. does have. I wouldn't necessarily say that they're ahead of us, but since 2011, they clearly are. We're only second to the United States, as I mentioned in my opening remarks, in the way of.
Thank you so much. I just want to remind members and guests that questions and answers should be addressed through the chair. That's just to eliminate any misunderstandings. We'll now go to Ms. Fry.
I guess I wanted to comment on one of the key points that was made in this presentation, and that was about federal, provincial, territorial collaboration and about lack of information and data at a national level. However, there is information and data at many provincial levels. And if we are to talk about federal, provincial, territorial collaboration to deal with this issue, I'd like to ask a couple of questions. We now know that OxyContin is a drug of choice as an opioid, that it is highly addictive, as all opioids are, and that in fact the provinces have asked, all of them, asked the Minister of Health to stop allowing for generic OxyContin on its formulary, and it asked the government to stop the production wherever it could by denying the ability of industry to make generic OxyContin. Not only did all provincial health ministers make this request, all provincial public health officers made this request, and it is my understanding that the Attorney General of the United States made this request. Now, the government's answer to this, and I know that it may not have been your answer, but I'm saying the government's answer to this, was to allow 6 generic companies to produce OxyContin. Now, if one is concerned about the use of OxyContin, its ability to be syringed up, mixed and used as intravenous, all of those things, why is it that one would not have stopped the production of the generic and gone to the OxyNew? To me, this is almost enabling a problem. Now we hear that the minister is saying, finally, about a year later, that she's considering whether or not she would listen to the United States pleas for this, because the United States realized that they stopped generic OxyContin, and now it's going to go across the border as a problem. I want to know why this was not listened to if everyone says that they care about the problem.
Please address your answers through the chair.
Thank you, Madam Chair, for the question. I will turn it over to Dr. Stewart, who I think is best placed to speak to the drug approval process, in this particular case, generic OxyContin, and if there is an opportunity after he responds to provide some data that we're aware of in the way of uptake of the generic OxyContin versions, as well as the new version of OxyNeo. I'd be happy to add that, but I want to ensure he has time to answer that part of the question. Thank you.
Excuse me, yes?
Before that answer occurs, I would prefer to get very crisp and concise answers because I have another question I want to ask in my period of time, if possible. Thank you.
Thank you, Dr. Fry. Dr. Stewart, would you, through the chair's reply?
Madam Chair, my response would be, in Canada, under the Food and Drug Act and its regulation, a drug will be issued a market authorization if, after risk-based decision-making process, Health Canada determines that the drug demonstrates safety, efficacy, and quality under its recommended conditions of use for the intended patient population. And that is the group under which we consider the information that is presented. OxyContin had a DIN, so the innovator product had a DIN on the market. A generic company under the Food and Drug Act and regulations can apply as a subsequent entry product if it provides both scientific evidence under pharmaceutical equivalency and bioequivalency to have a market authorization as a generic product. And for OxyContin, which had already been on the market, 6 generic companies were able to provide that information. Our Food and Drug Act and its regulations allow us only to consider the scientific evidence around risk, safety, efficacy, and quality in the intended population. Now, I'll speak to the comment about the U.S. approach. In the U.S. Food and Drug regulations, their regulations are somewhat different than Canada, and they do have the ability to consider implications of the product in patients or population outside of the intended use if it has a public health issue. So they have some flexibility in the way they can evaluate the evidence and evidence that might be related to abuse deterrence outside of the intended population. Under our framework in Canada, we have to focus on the intended use. And under that regulatory framework, the generic manufacturers were able to meet the bar to receive a market authorization.
May I?
Dr. Fry?
If that's the case, why is the minister considering that she might actually do what she was asked to do by all of the provinces? I think risk is a factor, you said, in allowing for a drug to be produced, and the risks were clear. All of the public health officers, all of the provinces showed the risk of OxyContin, a generic drug, being given as a prescription but hitting the street. And I happen to know, I was part of the SNUD committee that looked at this issue. People would get a package from their doctor and they would go out and they'd sell it on the street. So we know the risks. I'm saying if you wanted to have risk as one of your criteria, the risks were clear, and you were asked by provinces, and you say you want to work with provinces and territories, and you were asked by public health officers, so that we had an evidence base as to why one should get rid of OxyContin and not allow it to continue, remove the DIN, replace the DIN, based on risk of addiction and risk of street use. And so I don't understand why this wasn't done then, and why the minister is musing that she just might do it now. You haven't changed your regulations.
I remind you to direct your answers through the chair, and who would like to answer that? Dr. Stewart? Okay.
I can respond to that, Madam Chair. Our framework is as it is. We do look at risk. We look at risks to intended patients, the ones that the drug is supposed to be used in, and we ensure that it's labeled properly. We have a parallel set of regulatory frameworks that looks at the issue around diversion and abuse. And I'll turn in a minute to my colleague to speak a little bit about some of the additional measures that were put in place at the time that OxyContin was approved to hopefully reduce the potential of this product being abused or deterred. Our understanding is that OxyContin as a drug is a very valuable analgesic that's used widely to manage chronic pain. And there's a large burden of chronic pain illness nationally, and we've heard from many stakeholders that OxyContin plays an important role in managing those patients' symptoms. So there's clear efficacy, there's clear need, it's clear patient population where this product makes sense to have it available to. I'm all in support as a federal government in making sure that we can minimize the likelihood that this may be abused and deterred.
Thank you, Dr. Stewart. I'm sorry, now we have to go on to Mr. Wilkes. Go ahead, Mr. Wilkes.
Thank you, Madam Chair, and thank the witnesses for being here today. My questions will be directed toward Ms. Bruce and Ms. Gillis with regards to First Nations and Inuit programs. So within my riding of Kootenay, Columbia, I have what is referred to as the Three Voices Healing Centre, which is one of the 55 centres that is funded partially under the National Native Alcohol and Drug Abuse Program, of which you mentioned in your speech. Receives a portion of probably a portion of that $92 million that's given annually. I'm wondering if you could talk about what the proportion of First Nations and or Inuit people seeking treatment through the NNA DAP program are doing as a result of their use of prescription drugs. And then just second to that, Madam Chair, has there been an increased demand for treatment services through that program as a result of the misuse of prescription drugs in recent years?
Answer that question?
Yes, I'd be pleased to answer that question, Madam Chair. We have recently actually conducted a study within our NADAP, or National Native Alcohol and Drug Abuse Program, treatment centers to really look at the extent of prescription drug and polydrug use of people seeking treatment through these centers. And what we have found is about 30% of all people entering into the treatment centers also use opioids in addition to alcohol. Some could be using other types of illicit drugs as well. So about 30% of those. Through the increased knowledge around prescription drugs, the increased evidence there is that there's actually possibilities of working and treating prescription drug abuse as part of an overall treatment program, we are seeing an increase in the demand for prescription drug treatment in the NADAP treatment centers. We've had a very high success rate, actually, Madam Chair, during the research that we have done, that we found that 72% of all of the clients who are entering those treatment programs and had an opioid use problem left without an opioid use issue. They terminated the use. And of those small number of clients who didn't, they have almost 90% of those reduced the use.
Excuse me, I've just been informed that the bells are ringing outside. Is that, I need to confirm that. Is that correct? Can I have that confirmed? So they are ringing? There seems to be, are the bells ringing, Mr. Clerk?
I think they are.
Excuse me? Excuse me, are the bells ringing is the question. We'll just double check on maybe sometimes they just start and stop. Let's make sure they are for sure, Dr. Moran. Thank you for telling me, by the way. We had no indicators here at all. So can we double check that? Pardon me? Okay, are they ringing? Well, I'm going to have to adjourn this meeting right now, and so we will not be reconvening today because I understand the votes are going to continue on. But I want to thank the witnesses so much for coming today, and I'm sure we'll have a chance to have you back again. So, committee adjourned.